So HER2 is one of the well-validated biomarkers in patients with gastric cancer. It's well known in breast cancer, but it's very different from breast cancer. So that's something that we need to all be aware of. The immunohisto 3+, or patients who are 2+ for HER2 but are clearly amplified by FISH are the ones that we consider positive. Based on the TOGA trial, we saw that patients run around 10 to 23% chance of being HER2 positive. Patients which are the tumors that are more proximal, that are more moderately differentiated versus poorly differentiated, tumors that tend to be intestinal in their classification, Lawrence classification, tend to be more HER2 expressing. And the TOGA trial showed us that patients who got combination chemotherapy, cis-5FU, with trastuzumab had an improvement in their overall survival. So that becomes a standard of care in patients who have HER2 positive gastric cancer. They should be given trastuzumab. Whether you should continue it in second line and whether you should continue it forward is not well known. In fact, there are no compelling studies that show that you would want to continue them through, but that's probably still evolving. In addition, there's been similar studies to breast cancer looking at lapatinib and pertuzumab and seeing if we can get a better response in patients which are HER2 positive, and we don't see that, unfortunately. So it probably has a different biology than it does in breast cancer, but it's something that we have a strong targeted drug available for. For now, it's only trastuzumab.
As we said earlier, the key molecular testing for metastatic esophagogastric cancer is HER2 testing and perhaps later line MSI and PD-L1 testing. But about 20% of gastric cancers will be HER2 positive, about 30% of esophagus and GE junction cancers. So we would do immunohistochemistry staining as the first test. If they're strongly HER2 positive, 3+, they're declared positive. Equivocal is 2+, and then we do FISH testing. If they're FISH positive, then we consider them HER2 positive. If they're immuno 0 to 1+, we declare them negative and don't do FISH testing. We don't typically do FISH testing alone. The subset analysis from the randomized trial of trastuzumab showed that if a patient were only FISH positive and HER2 immunohistochemistry negative, they didn't tend to benefit from trastuzumab. So first line, we would combine a fluorinated pyrimidine and a platinum drug with trastuzumab. Although the regimen used in the trial was either capecitabine cisplatin or 5-day infusion, 5FU with platinum, with trastuzumab every 3 weeks, nobody uses this. We use FOLFOX with trastuzumab cycled every 2 weeks as the preferred dose and schedule.